Next important aspect is the morphology of cancer. On the USMLE, in terms of images, they probably will not ask a lot or show you a lot, but basically the way they're going to deal with it is in text form, either within the stem of the question or within the choices. And it becomes important to know the definitions of these terms and what they mean, because they're going to be a reflection of the pathogenesis of the disease process. In this case, the cancer versus benign versus malignant. So remember, cancer obviously refers to malignant. Benign refers to it won't have the capacity to invade or metastasize. So let's go through these characteristics. This is a table or a slide that's taken from your syllabus. So when we talk about benign tumors, in terms of the gross, they tend to be small size, but not always. Because if you go into the Guinness Book of World Records, you'll find that the largest benign tumor on record weighed 325 pounds. It was a dermoid cyst, which, as you recall, arises from the ovocytes, and basically it weighed 325 pounds because most of the weight was due to the accumulation of sebum, all that grease coming from the hair. It's one of the hairiest tumors you'll ever see, and it gets liquefied at room temperature, at body temperature, and then it becomes a basically oily grease, a sludge, or like toothpaste at room temperature. So they can get, typically when you pick them up early, they tend to be small, but if you let them go over decades, they can get up to 325 pounds. They're slow growing, so that means a very small proportion of cells are dividing at one time, and that's why when you look at microscopically in benign tumors, you don't see mitotic figures. They often are encapsulated or are well demarcated borders. Microscopically, you'll see expansion of the growing cells in that tissue. They're well circumscribed, the interface between the proliferating cells and the adjacent normal cells. They're well differentiated. In other words, they look very much like the normal cells, but more of them. And when you look at the genotype of the benign tumor, they are going to be diploid. They are non-invasive, and they never do what? Metastasize, especially on the USMLE. When we talk about malignant, what are the gross characteristics? They can be small, but they can also enlarge, and once they enlarge to a certain size, they will have the capacity or likelihood of invading and then metastasizing. So rapidly growing, what that refers to is that a greater proportion of cells are dividing, so mitosis on microscopic examination is more likely to be seen compared to benign tumor. And you may ask the question, what is the most fast-growing tumor in human beings where it can double in size in 24 hours is Burkitt's lymphoma. That's telling you that basically 99% of the cells in this particular tumor are dividing at one time. It's not that the cell cycle is shorter in malignancies, they actually could be normal or even longer. And what are some other gross characteristics? Because the expansion of the cell population, because there's a greater proportion of cells dividing, often the blood supply in terms of angiogenesis within the tumor can be lacking, especially in the central area, and can lead to necrosis. Now, since the USMLE is giving you clinical vignettes, what is probably the most common sign or symptom that a patient with a malignancy has that you always have to remember in any organ system is essentially bleeding. When you think of when you have hemoptysis, coughing of blood, what do you think of in the differential? Tuberculosis and cancer. When you have blood in the urine, you think of what? Besides infections, you think of renal cell carcinoma, urinary tract tumors. When you have blood in the GI tract, you have to worry about what? Colon cancer. You have to worry about gastric cancer, esophageal cancer, because when you have bleeding, this is one of the characteristic signs. When you have a mole on the skin that's bleeding, you have to worry about the upward migration of malignant melanocytes breaking down the epidermis and allowing bleeding to occur. So hemorrhage is probably the most common sign or symptom that the patient will exhibit, and you have to think of neoplasia as an underlying cause for that. They tend to be poorly demarcated because they have an infiltrative border. When you look at it microscopically, they can be well differentiated or poorly differentiated. So when we use poorly differentiated, what's the term that we use as pathologists is anaplasia or anaplastic. And biologically, poorly differentiated tumors that are described as anaplastic carcinoma, anaplastic blank, whatever it may be, tumor, that they have a poor prognosis because by the time you make the diagnosis, the stage is much higher and the likelihood of different therapeutic interventions are limited. Tumor cells will vary in size and shape. We call this pleomorphism. Because the malignant cells have over a period of time acquired a number of mutations, there will be chromosomal abnormalities. And when you think of the ploidy state of malignant cancer, you have to think of aneuploidy. They can have upwards up to 80 to 100 chromosomes in a malignant cell, and that's in contrast to the diploid state that you think of benign tumors. And because of the increased chromatin, what happens to the nucleus? It'll be larger relative to the volume of cytoplasm, so we call this increased NC ratio, as you recall. And characteristic on H&E is because you have more chromatin content, you have what is called hyperchromasia, basically increased staining because of the hematoxylin. And because these are highly metabolic cells, since a greater proportion of cells are now dividing in a malignant tumor versus benign, you will see a prominent nucleolus or nucleoli within the tumor cells. And in terms of mitosis, as I mentioned, is very common in malignant cells, as well as they may be abnormal. And then other characteristics microscopically, obviously, is invasion. And what do malignant tumors like to do as a function of time? Eventually, they will metastasize, go to a distant site from the primary site in which they have arisen from. So what's the gold standard in medicine, or what they'll ask you on the exam, is how do you make the diagnosis of cancer is going to be based on biopsy or microscopic examination of the tissue or cells. It's required to make the diagnosis, not by PCR, not by tumor suppressor genes, present or not, or serum tumor markers, which we'll describe in a moment. And so obviously an excisional biopsy or just a biopsy at the edge of the tumor, because if you have a malignant tumor going to the center, you're more likely to get necrosis rather than viable tumor. Another way you can make the diagnosis structurally instead of tissue is to get individual cells, so we use a fine needle aspiration. And then we have cytologic smears, and the classic one we think of is the Pap test. I know a lot of you have heard of it as the Pap smear. It's now, the correct term is Pap test. So when we talk about the diagnosis, once we look at the hematoxylin eosin stain and we want to decide what type of tumor it is, we can use immunohistochemical stains to identify various molecules that help tell us where these cells have arisen from in terms of their lineage and what product they're making. That gives us a clue, because by knowing this, then we can give the most efficacious therapy, whether it's surgery, chemotherapy, or radiation, to the benefit of the patient. And so it becomes very important. The IPOX is also, if you have undifferentiated tumor cells, where you can identify the origin and what the predictive value in terms of prognosis this is going to have for the patient, and what are the options at that point in time. So these are monoclonal antibodies, which can be specific to any epitope on the cell surface, inside the cell, or cellular compartments. And we can use these antibodies not only within the cell, but we can also use this clinically in what are released molecules from the tumor cells into the serum. We call these serum tumor markers. You can obviously, when you have a thyroid cancer making, for example, thyroglobulin, you make antibodies to it to show that it is of thyroid origin. There is a molecule that can be extracted which is 100% soluble in persulfate, and that's why it's called S100, and it's associated with neural crest derivatives like malignant melanoma as well as neural tumors. You can make antibodies to structural proteins like the contractile protein actin to identify, for example, smooth and skeletal muscle tumors like a leiomyoma or leiomyosarcoma, rhabdoma or rhabdomyosarcoma. Then remember that those CD markers you learned in immunology can be used for those cancers that arise in bone marrow and circulate. We call those leukemias. Or if they arise in lymphoid tissue, like lymph nodes, Pyrus patches in the terminal ileum, or your tonsils, or in the white pulp of your spleen, we think of lymphomas. And then obviously hormones that bind to receptors in cells, like estrogen, can be used like in breast cancer, and so this becomes important in terms of whether or not you use drugs like tamoxifen that can bind to these cells because they have the estrogen receptor. Then there's other class of molecules that can help the pathologist discern where these cells have arisen from. So these are called the intermediate filaments that are part of the cytoskeleton of cells. And we'll look at the next slide, which is basically a table taken from your syllabus that describes the 5 basic intermediate filaments, part of the cytoskeletal structure in cells. Why do they call it intermediate filament in size? You have the large filaments or structural proteins called tubulin, and then one of the smallest structural proteins, part of the cytoskeleton, is tonofilaments. What's in between? Intermediate. The way you want to break this table down is not just memorize it, but think of incorporating your embryology, because it helps discern why these particular intermediate filaments occur in various types of tumors. When you think of the ectoderm, mesoderm, and endoderm, and the neural crest derivatives, this is how you can help organize this table. When you think of ectoderm and the endoderm, they give rise to the epithelial cells. And remember that epithelial cells will give rise to carcinomas. 90% of all malignant tumors are carcinomas, so the intermediate filament is called cytokeratin. It's the same intermediate filament that you see in Mallory bodies, for example, when you have damage to hepatocytes, like, for example, alcohol. Then what about the mesoderm? Well, you have 2 intermediate filaments that you think of. One is for muscle and the other is for non-muscle. The non-muscle, we think of vimentin. We think of what are called sarcomas when they're malignant. And so you think of adipocytes for liposarcoma, fibrosarcoma, fibroblasts, and you think of diseases that involve the hemopoietic cells. They can also be vimentin positive. What about the muscle? When we think of smooth, cardiac, skeletal, we think of desmin. And you think of corresponding tumors, like the most common benign tumor of the female genital tract is a leiomyoma, and then a malignant tumor of the skeletal muscle would be rhabdomyosarcoma. Now, what about the nervous tissue? All neurons, including that are found in the CNS, PNS, and neural crest derivatives, are going to have, from the name it's obvious, neural filament. And so if you think of the neural crest derivatives, like a rare tumor except on the USMLE, is pheochromocytoma, because remember the medulla of the adrenal gland is a neural crest derivative. And then what about the other supportive cells that are critical to the function of the nervous system? Is the gliofibrillary acidic protein found in glial cells like astrocytes and ependymal cells. When we look at serum tumor markers as another way of helping us look at, in terms of understanding cancer, whether it's there or not, is that, remember, serum tumor markers are normal constituents of cells. And when you have a neoplastic cells that have more cells involved in proliferation, then the likelihood of these tumor cells making these markers and releasing them into the serum can be now used as a way of not ever making the diagnosis of cancer. And that's important. You never make the diagnosis of cancer based on the serum tumor marker, because there are processes that are non-neoplastic that can elevate them. So how do you make the diagnosis of cancer? Biopsy or fine needle aspiration. You need structural confirmation. And I'll illustrate this in a moment. When you talk about serum tumor markers, they're used for 3 main clinical purposes. 1, for screening. For example, if you have a middle-aged elderly population of males, you want to know whether you can catch the prostate cancer. Obviously, you screen the population if they have an elevated amount, because you look for PSA. However, we know that PSA can be produced by prostatic nodular hyperplasia, prostatitis, trauma, infarction. And so how do you follow it up if it's positive? Obviously, a biopsy. The second important reason why you look at serum tumor markers is monitoring treatment efficacy. You want to know that you've done the surgery, removed the tumor, and since you have the baseline of what it was elevated, once you remove the tumor, the level obviously should be decreased. And then the third is you want to know whether the patient has gone from remission to, again, reoccurrence of the disease. So it's detecting recurrence of the cancer, seeing the marker go up, and you have to be concerned, is it a neoplastic process or a non-neoplastic process that could elevate it? Let's talk now about useful serum tumor markers. And when we talk about the tumor markers, you can follow along your syllabus basically in alphabetical order. An important one is alpha-fetoprotein. It's found in two type of malignant tumors. You think of hepatocellular carcinoma, a new name for hepatoma. The other one is a non-seminous testicular germ cell tumor, and you think of yolk sac tumor, which is the most common primary testicular tumor in the pediatric male population. But remember, alpha-fetoprotein can be elevated in non-neoplastic conditions. For example, pregnancy, multiple births like twins or triplets. If you have a fetus that goes through fetal demise and dies in utero, it can also elevate alpha-fetoprotein. Again, how do you make the diagnosis of malignancy or neoplasia is biopsy or looking at individual cells. Another important one is beta-HCG. You think of trophoblastic tumors or choriocarcinoma, which is the most malignant germ cell tumor because it likes to metastasize by hematogenous spread, and trophoblastic tumors like a molar pregnancy. Remember, what are non-neoplastic conditions can elevate beta-HCG? The most common one in the universe is pregnancy. Obviously, if it's male, it's choriocarcinoma. Another one is calcitonin, a infrequent tumor, medullary carcinoma of the thyroid arising from the perifollicular cells. Then there's carcinoembryonic antigen, or CEA, which is found in a variety of cancers in the lung, pancreas, stomach, breast, and colon. What are some non-neoplastic conditions that can elevate CEA? Could be things like emphysema, smoking, gastritis, and ulcerative colitis. Then we come to tumor markers that are labeled according to numbers like CA125. CA does not mean California, but means cancer. And what does that 125 represent? The kilodalton weight of the glycoprotein in this case is using to measure as a tumor marker. It weighs 125,000 kilodaltons. And this is associated, elevated in malignant epithelial tumors. Remember, 2/3 of all malignant tumors that arise in the ovary are of epithelial origin. And so that when you have the most common malignant tumor is called papillary serous cis-adenocarcinoma. But remember, there are non-neoplastic conditions that can elevate CA125, like tubal ovarian abscess or endometriosis, because the most common place to find extra endometrial tissue is in the ovary. Then you have CA19-9 for pancreatic adenocarcinoma, but you can see it in pancreatitis, biliary tract disease. So how do you make the diagnosis is by biopsy. Then we talk about placental alkaline phosphatase. The most common germ cell tumor in the early reproductive age of males is seminoma. And then you come to PSA, prostate-specific antigen. And again, it's used for screening. You cannot make the diagnosis of prostate cancer on a PSA level because other things like prostatic nodular hyperplasia, trauma, prostatitis, infarction. And this is another important point. If you take 100 men who have known metastatic prostate cancer and ask what percentage of them have elevated PSA, it is not 100%, it's only 77%. So even though you have a malignancy, not all these malignancies that we've gone through that are associated with various tumor markers will produce a tumor marker. Remember, you don't treat the lab value, you treat what you see clinically in the patient. Another important characteristic of cancer is the grading and staging. And who's the person that degrades the tumor is obviously the pathologist. And the grade becomes critical because if you have a well-differentiated tumor or low-grade tumor, therefore it has a better prognosis. But if you leave the tumor alone and not treat a low-grade tumor, eventually it will develop a malignant phenotype because as a function of time it will acquire new mutations that will evolve into a more poorly differentiated as well as a more invasive as well as metastatic neoplastic cells. So for a poorly differentiated tumor, we think of the term anaplastic. And this can be based not only on differentiation, but the number of malignant tumors on the number of mitoses that are found. The tumor stage is a reflection of the biological behavior of the tumor. Are they going to ask you to stage tumors on the USMLE? The answer is no. But you do need to know the definition of tumor staging. And it's really important clinically because at the time of diagnosis of any malignant tumor, you want to stage it because that'll have important prognostic as well as therapeutic choices for that particular tumor. What's the normal stage? Basically, it's stage 1 through stage 4. Stage 1 is usually a small tumor confined to an organ, while stage 4 is metastasis. What's 2 and 3? In between. So the staging system is described, as you remember, is called T and M. T for tumor and the size of the tumor, N for the extent of lymph node involvement by lymphangitic spread of the tumor, and then obviously M is for the presence of metastatic disease. And obviously the lower the stage, the better the prognosis, and sometimes the tumor grade will be critical as well. But there are some tumors that are well differentiated that are biologically very aggressive clinically in terms of metastasis. What's a classic example of this is follicular carcinoma of the thyroid. So we always have to remember that neoplastic processes over a period of time, since it's a multi-step process, are going to go through a Darwinian evolutionary changes. So we call this process tumor progression, because as the tumor over time, it can develop a more malignant phenotype, or the cells could develop lethal mutations and die. So if those cells that can survive these mutations and now develop a more malignant phenotype over years or decades, then this is called tumor progression. And this can start from biochemical changes early on, where it can go through a hyperplasia, dysplasia, metaplasia, and then go on to carcinoma in situ before it invades through the basement membrane, and then you get a malignant phenotype where it can now break down the basement membrane, now cause invasion, and then have the characteristic of now developing metastasis and causing destruction to distant sites where organs will be infiltrated by this neoplastic process, but it takes time for this process to take place. So therefore, at the cellular level, there's a natural selection that's going on, and that's why you think of it like Darwinian evolution at the cellular level. And those cells are able to live with little nutrient source, live under a low oxygen tension, are obviously going to have a better survival compared to those that are more dependent upon the environment in order to sustain their growth. And you always remember that the fidelity of DNA in malignant cells is unstable, and therefore mutation rates are much higher in these neoplastic cells compared to their normal counterpart in the cells around them. The last thing we have to talk about in neoplasia is metastasis, or widespread distribution from the primary site or origin. And what are the initial routes of metastasis that you always have to be reminded of? Because the lymphatics are the thinnest vascular vessels and provides a conduit to other sites through the lymph nodes. Eventually, the lymphatic drainage to the venous system, and from that point on, it can spread to multiple sites. So lymphangitic spread is the most common route. It's a spread especially for epithelial tumors or carcinomas, while sarcomas tend to be more hematogenous. And so in the hematogenous, you think of what? You think of sarcomas. A classic one that I like to ask about is osteogenic sarcoma of the bone. And then you think of renal cell carcinoma. It likes to invade into the renal vein. It can extend up into the inferior vena cava and actually grow like a snake into your right atrium. Hepatocellular carcinoma has a propensity to invade into the portal vein as well as the hepatic vein. And the most common place you want to look for metastasis in the case of hepatocellular carcinoma is the lung. And then, as I mentioned earlier, follicular carcinoma has a propensity for invading into vascular structures in the thyroid and has a poorer prognosis versus papillary carcinoma of the thyroid is slow growing, as well as it tends to spread by lymphatics to regional lymph nodes in the neck. Choriocarcinoma is the most deadly germ cell tumor, both in men and women, because it has a propensity to invade into veins, vascular structures, and spread to multiple sites. Another route of spreading cancer is to get into body cavities. We call this seeding or implantation. What are classic examples? Primary adenocarcinoma of the lung or ovarian cancer, because remember where the ovary is located within the pelvis, but it has direct access to the peritoneal cavity and can now spread and now use the serosal surface of the abdominal cavity of organs to now start growing and spread further, and then leading to things like bowel obstruction. The ability to basically transplantation of malignant cells from mechanical manipulation, for example, surgical incision or needle tracks. But these are extremely rare and probably will not be asked on the USMLE, but can occur. What's a cancer that can be associated with this is primary osteogenic sarcoma when you try to do a fine needle or a core biopsy, that tract site is often removed as well once the bone that's affected by osteogenic sarcoma of the bone will be taken with the specimen.